Good evening and welcome to First Aid Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados and your hostess for this evening. First Aid Chats by Dr. G is a live podcast that provides listeners with the unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled Sickled in Pain, and our guest is Dr. Cheryl Alexis. Dr. Alexis is a hematologist who was born and raised in Trinidad and undertook her MBBS degree and graduate studies in child health at the University of the West Indies, Mona campus in Jamaica. Subsequently, she went on to do her master's in hematology from the University of London, and she is currently a member of the Royal College of Physicians. Dr. Alexis undertook fellowships in adult and pediatric hematology and oncology at the Hammersmith Hospital in the UK and pediatric hematology and oncology at Great Ormond Street Hospital for Children in the UK. Her research interests are in genetic risks of breast cancer in Barbados, pediatric cancer, and hemophilia. She is also the lead physician for the Caribbean Sick Kids Initiative with helping children in the Caribbean with cancer and blood disorders. Currently, she is a senior lecturer in hematology at the University of the West Indies Capel campus, as well as a consultant in hematology oncology at the Queen Elizabeth Hospital and Bayview Hospital, Barbados, in addition to maintaining her private practice. Of note, Dr. Alexis is a very fun loving person. She was a lecturer of mine when I undertook the program, and she sings with an old time calypso band called Free Spirits. Good evening, Dr. Alexis, and welcome. Please feel free to call in at this time. Dr. Alexis, are you with us? I'm just going to ask you to just look for either the red or the green couch and just call in. Good evening, Dr. Alexis. I'm hearing you now.
Good evening, Adana.
Thank
Are
you.
you hearing me now?
Yes, I am. Thank you so much for joining us this evening.
Well, thank you for having me.
Yes, I wanted to start this evening, Dr. Alexis, because we know that Barbados does have relatively a high prevalence of sickle cell anemia. And so I really want to start off with very basic. What is sickle cell anemia, Dr. Alexis, for our listeners?
Okay, so sickle cell anemia is really an inherited disorder that affects your red blood cells or hemoglobin. We say sickle cell disease because there are heterozygous and homozygous types. So when we say sickle cell anemia, we refer to the patients who have both the on both hemoglobin S gene. I'll explain a little bit later. Those who we say sickle cell disease may have like a hemoglobin S gene with a hemoglobin C gene. Now, the main thing about sickle cell disease, which is what I would call it to encompass everything, is that it is a mutation in the one of the genes called the beta gene of your hemoglobin molecule.
Mm,
Your hemoglobin molecule has two genes, an alpha gene and a beta gene. Actually, two alpha genes and two beta genes. That makes up your hemoglobin molecule. So, in patients who have normal hemoglobin, which we call hemoglobin A, they have two normal alpha genes and two normal beta genes. What happens in one of the beta genes, in the beta gene, there is a mutation, a point mutation. So, what does that mean? Is that one of your amino acids is replaced by a different amino acid at a particular point in the gene. Okay. In the case, most all medical students, when you ask them, they would know that it's glutamic acid replaced by valine on position 6.
mm,
Okay. And what does that little mutation that happens really causes a lot of problems. It
mhm,
changes the shape of your red blood cells. So, your red blood cells are normally donut shaped and very flexible. So, it moves through the blood vessels very easily, and blood flow can be maintained, especially in patient in in normal situations,
Right.
and especially in your small blood vessels.
Right.
When you have the change in the shape, and the name is derived because of the shape of the sickle red blood cell. It's shaped
Mhm.
like a sickle, and it's shaped like that, and it also makes it very stiff. So
Oh,
going through the blood vessels, it does not um, it does not allow blood flow to be very good in those areas, and actually sticks in the blood vessels. And after a while, the blood cannot bypass. It forms like a barrier,
hmm.
and the blood cannot flow past that. And as you know, if you get any decreased blood flow, you can't get blood to your tissues. The tissues eventually die. And these situations happen more when the oxygen levels are low for whatever reason in the blood. So
Okay.
the red blood cells are deformed, and it can cause things like what we call hemolysis, which is breaking down of the red blood cells.
Right.
And because the red blood cells are broken down, you get anemic, meaning that you have decreased amount of red blood cells. And the main problem that sickle cell patients have are painful crises caused by the death of the tissues, like in the bone marrow, what we call bone marrow infarcts. You
So,
can also get
so,
um,
so Dr. Alexis,
death.
I, Doc-
Sorry,
I
yeah, go
just
ahead.
just want to interject one quick second. I just want to get some clarification before we really start to go into some of those findings. But you said the amino
Hmm.
acids, so these are really the building blocks of our DNA and things that code for certain presentations. Things like, for instance, our eye color, what color our hair would be. This particular
Exactly.
information
Hmm.
codes for how our red blood cell would be shaped, and that's where we
Right.
that mutation, correct?
Yes, that's correct. And
Okay,
it is inherited because we inherit all our DNAs from our parents, half from our mother and half from our father.
great. So you were going on to tell us about some of the presentations of sickle cell disease, how some of those persons can present. But certainly
Mhm.
before we do that, can you just tell us a bit about some of the risk factors? Because you already said mommy and daddy. So when would a person really think, hmm, should I even investigate to see if I have sickle cell anemia? What would cause a person to think about it? Because you started to speak about some of those symptoms that would cause someone to think they may have sickle cell anemia.
Yeah, so it is inherited. So our hemoglobin gene has two strands, as I said. And for normal people, you have two strands which are hemoglobin A. So we identify that normal people have what we call hemoglobin AA.
Okay.
Okay. Now, if you have the mutation in one of your strands, and you have the hemoglobin S, if you have hemoglobin A and hemoglobin S, we call you what we call that sickle cell trait, and that means that you are a carrier.
Okay.
Yeah. So what happens, as I said, the inheritance pattern, you usually inherit from your one half your genes from your mother and half your genes from their father. So
Right.
for you to have sickle cell disease, it means that you have to inherit the sickle cell gene trait. First to begin, your parents have to be sickle cell trait at least,
Okay.
and then you have to inherit the sickle cell, the hemoglobin S gene from both parents. So then you are hemoglobin SS, and that is what sickle cell anemia is. So, and with each pregnancy, there is a 25% chance or 1 in 4 chance of how the genes match up, and you can get sickle cell, a 1 in 4 chance of the baby having sickle cell disease. That does not mean that if you have four children, only one could be sickle cell. Is with each pregnancy, there's a 1 in 4 chance. And there are families who have four children and all four might be sickle cell, or none of them might be sickle cell. It just depends on how the genes mesh when the embryo is being formed.
Right. So you started off by telling us just now some of the symptoms associated with crises. You said you can get these painful crises in the bone marrow, but
Mhm.
tell us a bit more about those painful crises and where they can present. Where can persons actually start to get some of these painful symptoms?
So the painful crises basically follow where you have active bone marrow because that's where they are, where the pathology lies. And so you as a baby you have active bone marrow throughout your skeletal system, and as you get older, it goes more centrally. So with babies, you can get what we call dactylitis, and it is manifested by pain, very painful and swollen fingers and toes. Now, it might only be on one side or it might be on both sides. It may involve the hands, it may involve the feet, or so. Sometimes it might be just one finger. So that in babies, and as they get older, it gets to the long bones. So they get pains in their joints, their long bones, and then their chest, pelvic area, and their spine. So you
Um,
find like by teenager, they start talking about back pain. Um,
so, Dr. Alexis, when you say the long bones, exactly you're talking about the femur in terms of the bones and the top bones in
yes,
the
and
leg
your
and the
right in your upper and lower limbs.
good, good, excellent.
Mhm.
So the child can present with, as you said, dactylitis, which are these painful swollen fingers and toes. And as they
Yes.
get older, they can then present with pains in some of the long bones, limbs, and the bones in the upper limbs and lower limbs, as well as chest pain. Tell us a bit about that chest pain.
So the chest pain is usually like a central chest pain. And that basically, once you have that, sometimes it can be the start of what we call acute chest syndrome, which is where you get sickling within the lungs. So you don't only have sickling or sickling in what we call sickling is when the sickle cells are in the bone marrow, but you can have them in your organs as well. And if not, you know, looked after properly, patients can get irreversible end organ damage, so damage to their various organs. And this acute chest syndrome is actually a medical emergency, and you have to diagnose it early for effective treatment.
Okay. Are there any other symptoms that, for instance, a patient can present with? Because I know we, when I was in medical school and we went through sickle cell disease, certainly we would often hear about the bread and butter symptoms that you would have. But are there any other symptoms that a patient can present with, like for instance, in the male population, that they might even be embarrassed about and they don't know that it is associated with sickle cell disease?
Yes, in the male population, we get what you call priapism, and that is when you have sickling within the corpus callosum, or the muscle in the penis. So what they have is an erection, and we define it as an erection lasting over 4 hours. So that is also a medical emergency. You
Right.
have things like, because your cells break down, it produces what we call bilirubin and cause jaundice in the eyes,
Absolutely.
paleness in the mucous membranes because of the anemia. And interestingly, I had a patient who presented at 65 years
Wow.
old with gallstones, and he didn't have the usual thing that were gallstones, and the gallstones didn't look like normal other gallstones. And he turned out that he had sickle cell disease, and he did not know that he had it
Hmm.
until he had that diagnosis of gallstones at 65.
Wow. And
Yeah.
and this is with sickle cell disease and not sickle cell. Oh,
Yeah, he had sickle cell with, I think what, I don't want to complicate things, but with thalassemia gene. So, yeah,
oh,
so the disease was
severe.
less problematic. I mean, on questioning retrospective, Lee, he did talk about sometimes he would have these joint pains or these pains, but he didn't really think anything of it. And, he just went along.
Okay.
Yeah.
Okay.
Mhm.
Also, persons can present with, especially for those children, they can present with an enlarged spleen. Can you explain to us why sometimes children can present with an enlarged tummy? Because mommy might not know that it's a spleen that's enlarged.
Mhm.
But why would a
Right.
child present with an enlarged tummy?
Okay, so an enlarged tummy can mean that there is enlargement of the organs in your abdomen. The major organs there that would cause problems is the liver and the spleen. Now, the spleen is on the left side of your abdomen, and that is responsible for two things. One, it acts as a filter to filter your blood. So any abnormal things in the blood, any abnormal blood cells, it will filter it out, strain it out, so it doesn't go back into the circulation, and then it gets destroyed in the spleen. And then the second thing, it it prevents you or protects you from certain bacterial organisms,
Right.
and bacterial organisms in terms of sepsis or infections.
Right.
So those are the two main duties. Now, remember I said before that the red blood cells are deformed, and so when they go into the spleen, if you have a lot of deformed red blood cells, then the spleen will try to strain it out. But then the strainer or the colander, whatever you want to call it, is not big enough. So
Mm-hmm.
what happens is that it clogs up, and therefore the rest of the liquid blood cannot get through. So the spleen is made up of like what we call like little lakes or
Oh,
sinusoids, we call them. So that gets full, and that is what caused the spleen to expand. That is also a medical emergency. And because all the blood gets trapped in the spleen, and then the patient does not have enough blood to go around the body. Over time, because the spleen gets insults, what we call infarcts, it actually dies and is of no use after a few years in patients. So, what we call auto infarction or autosplenectomy, meaning that the spleen is no longer functional. This
mm,
happens over time because of the insults to the spleen by the lack of blood supply over time.
okay. So you said that these patients generally will present in lots of pain. Sometimes they may present in a medical emergency, depending upon which part of the body is involved. Um,
Yes.
but you also highlighted just now that they will undergo autosplenectomy, or essentially
Mhm.
where the spleen becomes defunct and it's no longer working. Um,
Yes.
are there any measures? Because I know a lot of persons sometimes when they get a particular diagnosis, sometimes they may think, oh dear, my life is ruined, or how am I going to even cope with this? Is there really life after having a diagnosis with sickle cell anemia?
There is life, and treatments are getting better and better, and we know more about how to prevent certain things. So, like in um, in days before, years ago, maybe in the 50s, 60s, when people weren't too sure, maybe the 40s really, weren't too sure what was going on, a lot of children died before the age of 2 because of this, the spleen not being functioning and therefore not being protected against these bacteria or germs that the spleen protects us from. So this has caused over the years implementation of what we call prophylactic antibiotic treatment, meaning preventative. So we give the children antibiotics to prevent the infection by these bacteria or organisms.
Right. So, is are there any other interventions that, for instance, during a crisis, that someone can provide themselves with, or do you recommend that every single time a patient has a crisis, that they should present to their doctor? Should they seek help?
Well, the thing about it is that no, what you try to do with these patients, because they are going to be living with this for the rest of their lives, and you want them to have as normal a life as possible. So you try to help them through managing them or managing their disease. So I'll talk a little bit about like acute problems and other things that we can use to modify the disease problems. So acute problems, as I said, pain makes up more than 90% of their problems. And a lot of the times over time patients learn how, when they, some of them may know when they're getting pain, or sometimes they know that certain triggers trigger the pain. So you teach them to be proactive. Now, giving, there are pharmacological things that you can give, and including painkillers, and we have a pain scale that we use. But there are also non-pharmacological things that can be taught to patients to help with managing pain. Things like physiotherapy, biofeedback, and a lot of times, some patients actually do learn on their own how to not think about the pain. So sometimes you may see them being either reading or looking at the television or something, and it's like a distraction therapy. So it distracts them away from the pain so
Right.
they don't think about it. And when it is very bad, when they have tried everything at home and it is not working, then they may need to come in to the hospital, or to present to their doctor for
Right.
treatment, sometimes with intravenous therapy.
Okay.
Mhm.
I have actually within our audience this evening two persons, two patients essentially, who have been diagnosed from childhood with sickle cell disease. And I am going to, at the very end, allow them to share just a bit in terms of, because you said that, yes, there is life absolutely with a diagnosis of sickle cell anemia, sickle cell disease.
Mhm.
And I thought
Mhm.
it was important just to really hear from them very briefly, what life is like. Quite often, we would see persons who are afflicted with this condition, sometimes presenting, as you said, for pain medication because sometimes the pain can be quite severe. It's
Mhm.
a situation that quite often we can sometimes, both as sometimes family members and or caregivers, um, underestimate or sort of try to to state that this pain is not that intense. You should be accustomed to this by now. Tell us a bit
Um,
about how those persons sometimes suffer in silence, if they do.
yeah, they are definitely silent sufferers. Now, the thing is, when you get accustomed, I don't like using the word accustomed. I can't think of another word right now. When you are accustomed, so these patients live with pain,
Yeah.
okay, and they learn to control it. Some of them tell you that they have pain every day of their life. Some days it's low, some days it's high, but they have it every day, but they learn to live with it. Now, there's a difference between the pain, like in sickle cell, and acute pain. So if you break a leg or an arm or something, or you have acute appendicitis, you have an acute pain. The problem, the pain resolves when the problem is treated.
Right.
Sickle cell patients, the thing about their pain process is that it is a process. We cannot get rid of the pain. All we can do is make them comfortable through the cycle of the pain. So it goes through a cycle where there is like a crescendo, exponential increase in the pain, and then it reaches a plateau at the top, and then it starts to subside. Now, that cycle of pain can last hours, it can last weeks, it can last months. Okay. So our job is to try and get them through that high plateau where they are going to get, see where they have the most severe pain. Unfortunately, a lot, and this is not only in Barbados, all over the world, um, sickle cell patients get a raw deal because they have learned to live with their pain, so they don't do so. If you have a person there who has like an acute appendicitis, they might be screaming and whatever, and because they live with their pain, they know how to kind of internalize it, so they don't make a fuss. So you, as you rightly say, a lot of people think, oh well, you're not really having that bad pain. The other thing is that they know what works for their pain. And usually, when it's severe pain, we usually have to, um, go to opiates or things like morphine and so to treat the pain. Um, and so there's a so and believe it or not, a lot of sickle cell patients do not want to take it unless they have to. So sometimes if they go into emergency room or to somebody who doesn't really know them, um, they may come and say, well, this works for me, and then unfortunately, some healthcare professionals take it as, oh, well, um, you want the opiates or whatever, you are addicted to it or whatever, and that's very unfortunate. And it is important that we get we haven't we're not there yet in Barbados, but it has been shown that if you have centers for patients with sickle cell disease where they can go and they are known, their time where they will be treated with pain is lessened, because the patients know the patients are known by the treating team, and they know what to get and what they are. And this is another topic for another time, but there are a lot of what should I say, things around morphine and the opiates, and people have very prejudices against it.
Things.
Yeah.
Absolutely, absolutely. I see we have a question here on the message board. Good evening, doctors. Writing in from the US. What is the pain management protocol upon entry to the emergency room in the Caribbean? My 6-year-old was given morphine at home and then fentanyl in the ER. The thought of fentanyl really bothered me. Is this normal practice? And I think you actually started to go into this here just now, Dr. Alexis, but I'll leave that
Yeah.
to you.
Well, the thing about it is that if it's severe pain, we usually call, like the pain specialist. They have a protocol. They use whatever works. I mean, morphine is usually our drug of choice
Hmm.
that we do, along with other, as I said, we had a pain scale, our non-steroidal anti-inflammatories, and so. And sometimes we do have to go to fentanyl, but we don't do that under the supervision of like the anesthetists who are more familiar with this. So sometimes they use a combination, and it's not like a one thing for all. It depends on the patient. Unfortunately, we have had protocols in the past, like mainly for the emergency room and so, but these need to be updated, and I think that needs to be done. So, unlike in the US or in the UK where I used to work, they have certain protocols, but the protocols are developed, but you have to remember that we still have to treat dependent on the patient. So you may have a guide, but then you would use your judgment as the physician to decide where, we need to go with that.
Certainly, because the objective really is to take that person out of the grave pain that they're in.
Exactly. Mhm.
Absolutely. Dr. Alexis, what is the sickle cell disease profile like here in Barbados?
Well, unfortunately, I know you said about my I did not really that was not what I have researched on, but others have.
Right.
And there was a study done. I don't remember when that was done by Dr. Anne St. John, Professor Anne St. John,
Right.
and it has been published in the West Indian Medical Journal, where the gene frequency was found to be 4%.
Right.
To put that into perspective, places like St. Lucia, who has an ongoing neonatal screening program for over 10 years, their gene frequency is 14%.
Right.
And like in places of the US, and so is about 8%. Jamaica, it's about 9 to 10%. So ours seem very low, but I think that we need to do further studies to really get it, because that was a very small study on just 1,000 babies
Right.
at the time. And the thing with some of these, dependent on the technique that is used, you might miss some of the patients who do not have S or C, and have some of the other sickle cell syndromes.
Right. How long does a person generally live with sickle cell disease? Is their life cut short based upon this pathology?
No, well, we had the oldest person I know with sickle cell disease was like about 95 when she died, but
Right.
she died from anything unrelated to sickle cell disease. And basically, there are things that makes the disease more severe in certain patients
Mm-hmm.
than others. And obviously, the more severe it is, you may have like a diminished outcome. But we do try to, increase your longevity, as it says, with the modern medicine that we have now, with disease modifying drugs that are used.
Okay, we have another question here. Good afternoon, doctors. Does a person's weight become a problem? I'm asking because I'm almost 300 pounds, but I am tall. I have been diagnosed with HBSC, and I have been prescribed with pethidine and arcoxia on two separate occasions. Basically, I'm asking, does size matter?
Uh, well, does size matter? Size matters if you have an illness, a non communicable disease.
Mm.
And obviously, your lifestyle would also compensate. That's another thing because before, these sickle cell patients used to look very skinny, tall. Some of them look malnourished, and so in days of yore. So because of the better lifestyle, better diets, and everything, sickle cell patients look absolutely normal. And some of my patients tell me, oh, people say, oh, you can't have sickle cell disease. You don't look like a sickler, whatever
Right.
that means. So in terms of things like that, I think that you have to have a good diet. Health, we say healthy lifestyle, but minimal exercise, try to keep your weight down, and eat healthily. So yeah, in terms of that, I guess size does matter to a certain extent.
Right. Okay. I want to ask Dr. Alexis, um, a person presenting with or having family members with the trait. You sort of alluded to it quite early on in our conversation about sometimes the person can present with hemoglobin S and other times they can present with hemoglobin C. And this last listener actually mentioned the fact that they had SC disease. Tell us about a bit about SC disease. Is it any different from SS?
It is different because the C sort of modifies the problems with the S. So they usually have less severe disease.
Right.
They tend to have higher hemoglobin. So sometimes they may not even be anemic at all.
Mm-hmm.
And sometimes they don't get into any problems unless they have some insult or something like that. And because of the in SC, because of the higher hemoglobin, there are certain things in those patients that we have to look out for. So
Right.
they can get like bleeding behind the eye, and so because of the higher hemoglobin, so you can get thrombosis, and so what we call retinal vein infarction or occlusion, and that is something. So every sickle cell patient, no matter how mild or so the disease, we also tend to tell them that they need to have an ophthalmology review at least once a year. The
Right.
other thing is that because of the high hemoglobin as well, it almost like a hyper viscous state.
Mm-hmm.
They are more tend to get what we call avascular necrosis of the hip, where you get the bone on the femur between on the hip bone, the acetabulum being eaten away because of the insults and the infarcts that happen within the bone. So those are the two things that you find more in patients who have less severe disease, well, less severe presentations of disease, I should say.
Okay, good. Do we tend to see disease more in men or in women, or is it any different?
It's not different because it's not sex linked.
Right.
It is, so anyone can have it. The only difference is the priapism in men, obviously, because they have a penis.
Right.
But other than that, yeah.
I see here. Thank you for asking that question for me. But I have asthma and PCOS, but my blood count isn't high. And then we have another listener. Can Dr. Pressure? Can Dr. Let's just make some brief comments on gene therapy?
I know that had to come from Patsy. Anyway. Okay, so before I say that, Patsy, maybe we need to go into just they have some disease modifying drugs, and the one that we know of is hydroxyurea.
Right.
So, hydroxyurea is one of the things that have been being used for over 30 years and has really made a difference in patients' lives. Also, that and chronic transfusions, but that obviously comes with side effects as well, have made an impact on that. The hydroxyurea initially got some bad press because it was initially thought to be, well, used in pre-cancer conditions. So it was labeled as a cytotoxic drug, but the side effects that you get, is much less than the benefits these patients have. So how hydroxyurea works is that it increases your hemoglobin F level, or fetal hemoglobin,
Right.
which is the hemoglobin that you have when you are in the womb,
Mm-hmm.
and that helps to hold on to the oxygen better. So, because of that, you find that patients don't have as many sickling crises and complications. Another thing that it does, it prevents the stickiness, because in addition to the sickle cell and the fragile nature of it, is also very sticky and adheres to the walls, and so causing problems. So it decreases that as well. Okay.
Right.
So I can talk a little bit about gene therapy. So um, our whole DNA was, I think it was in the 1990s or something, that we knew it was identified. And using people with genetic disorders. This looked like, like if you can take out the gene and replace it, that would be great. Now, that sounds easy, but it is not so easy. So, one, to get the gene in, you have to find a vehicle. And you have to find a vehicle in the gene that can actually populate the bone marrow with normal cells. So, two things when you're looking at gene therapy. One, you have to get rid of the patient's own bone marrow cells. So, you have to give them chemotherapy, what we call conditioning therapy, and so, and to remove their cells. And two, what we do is we take some of their blood cells out of their body, put it in a dish, use a modified virus that it's actually related to the HIV virus, and it carries the DNA coding for the oxygen, um, that would compensate. So you put that into the patient's stem cells, and that compensates for the defective gene. And then after you remove the patient's bone marrow, you then give them back their own stem cells. Um, the and then they populate without the defective gene. So basically, they don't have sickle cell anymore because they don't have that point mutation in their gene. Okay. The first patient was done, I want to say maybe about 10 years ago. But unfortunately, that trial was stopped recently, because they noted that two patients who were treated about 5 years ago developed leukemia. One had acute myeloid leukemia, and one had what we call myelodysplastic syndrome.
Right.
The chemo, they're not sure what it was, if it is the chemo that was used to suppress the patient's cell or to wipe out the patient's cells, or if it is something to do with the method itself. So
Hmm.
that is being investigated, but this is only recently. So that has put a kind of a dent into cures for sickle cell.
Hmm.
However, a couple last year, I think, they had about 2 years ago, they had what we call gene editing technique. So in the actually the first two patients that were done, that was published in the New England Journal of Medicine in January this year. And what they do is they edit the gene. So what they do is they use like electricity to zap out what a part of the gene that um, stops hemoglobin F from being that. There's a gene called, well, BCL11A gene or what, and that stops the red blood cells from making your hemoglobin F. Okay, so that is like a switch off gene. So that switches off when you are born, right? So
Hmm.
what they try to do is that they snip off, they zap it with electricity to sort of, so they remove it altogether. This is done ex vivo, so in a dish, and then it's put back into the patient. So they zap that part of the gene. So what you find is then the patient continues to make hemoglobin F, which, as I said before, is protective
Hmm.
for severe disease. So they did two patients. One was sickle cell disease, and one was thalassemia, which is sort of related. And those patients so far have been, they now about 21 months, 23 months with follow up. And they have had some complications or adverse reactions, but which were all treatable, and they have improved, and they don't need any blood transfusion, painkillers. Their blood results have normalized, and so.
Hmm.
But since this was studied, they have about 8 more patients in that. But it's too early to tell. But it does seem like there's a little bit of hope on the horizon with that gene editing.
Absolutely. We have one last question here that we're going to take. Good evening, everyone. Could Dr. Alexis speak to how the pathology of SCD or sickle cell disease compares to other hemoglobinopathies like HBC? So, Dr. Alexis,
Like
what is
sorry.
HBCC? So, Dr. Alexis, what is HBCC for our non-medical listeners out there?
Well, it is sickle cell disease. It's just that you have inherited two hemoglobin C
Great.
genes instead of S.
Mm-hmm.
So the pathology is basically the same, and the same things can happen. But the variant of C seems to have less complications
The traditional S.
than the S, yeah.
Right.
So they do have less complications. The patients they have less complications, and so, and but they are still at risk of getting all the complications that hemoglobin SS disease patient has. So they still need to be careful and take note that it is. And, there have been some, I mean, I've heard patients come to me who had hemoglobin CC and they was told, oh, you just have a little sickle cell, nothing to worry about. There is things to worry about. So anytime your hemoglobin is not A, either one is not A, you have something to worry about.
Hmm. Can sickle cell anemia cause stroke? That's my last.
Yes, it can.
One. Okay.
So it does. You get infunctions into the brain, and you get infarction, so you get an infarcted stroke as opposed to a bleeding stroke.
Right.
And it is, and obviously in younger patients and in children, we see it. We have quite a few children that have gotten strokes. And it is, again, a medical emergency. So you have to act on it quickly so that they don't have any adverse effects once we start the treatment and start reversing the effects of the stroke.
Okay. Great. Dr. Alexis, at this time, I am going to invite my first guest, one of the patients that I know near and dear to me, who actually was diagnosed with sickle cell anemia, to just give us brief words in terms of what is a day like with, from the standpoint of a patient with sickle cell anemia. I'm just going to ask him to call in right now.
Okay.
So we actually have both of them calling in, and I'll take them both at the same time. Okay, great. So I'll start. Well, you can introduce yourself. We have Nika, both Nika and Tonya, on with us this evening, and they were both diagnosed with sickle cell disease. Tell us, what is it like in the day of a life as some person who is diagnosed with sickle cell anemia?
Well, this is Tanya. I guess I can go first. Can you?
Okay, sure, we can hear you.
Okay. Good evening, everyone. Well, I'm 41, 41-year-old female. I was diagnosed at 7 with sickle cell anemia by a and I tend to have a less severe um, experience with my sickle cell anemia because Um, there may be some beta thalassemia mixed up in there, but I've never had any diagnosis to confirm this. But typically, I have crises around every 7 years, give or take, and um, basically in any given day, I make sure that I'm well rested, well hydrated, I stay warm, and I try to pace myself. I know that I can't do high intensity activities, but once I pace myself, I can keep up with everybody else. But when I was growing up, that was back in the 1980s. There was a lot more um, less hopeful things that doctors would tell patients with sickle cell anemia, like, oh, you can never play sports, you can never do these things, your lifespan is going to be up to age 30. I'm living proof that that is not the case. I was on almost every team in secondary school, tennis team, netball team, volleyball, swimming. I ran track at interschool sports. I mean, I did almost everything.
Right.
Um, so, um, I mean, there's not much that we can't do once,
You're well managed.
you're well managed and you manage your condition and you know your limits.
Great. Thank you so much, Tonya.
No
And
problem.
Good night. Can you hear me?
yes, we can hear you, Nika.
My name is Dr. Nika Brown. I am 26 years old. I have HBSS. Um, a day in my life, more recently, has been a little difficult due to the pandemic.
Right.
But on the average day, I can keep up with all of my peers. My usual sickle cell presentation may have me in a painful crisis, which requires emergency management, um, maybe once or twice a month. And once a month is more regular, once a month. Um, but if I try to push myself too much, which I tend to do, um, I may have regular pain, what I call regular pain for myself. I usually experience some level of pain every single day. Um, but it's something, as Dr. Alexis mentioned before, that you can ignore if you hyper focus on something, which is what I tend to do. I
Right,
read a lot when I'm in pain, um, or I would just focus on my work. So those are the two things that I would hyper focus on, and I could tend to like just ignore it, keep it at the back of my head. And those would be my level 5 or 6 pain. And
right,
that's where my everyday pain would be.
right.
But once a month, I might have a 9 or 10 that would require emergency management.
And, and
Um,
and I'm actually glad to hear, Nika, because you have finished medical school. You're a practicing doctor, so you can. There is normalcy with sickle cell disease once again managed properly with the help of other doctors that can help you. Antonia, in terms of other doctors that can help you and assist you with coping and ensuring that you have the best possible management.
yeah, of course, sickle
Yes.
cell has the can be as well controlled as any other non-communicable disease. Um, just like if you have diabetes, if it's poorly controlled, you'll be extremely symptomatic. If you are well controlled, it's something that you wouldn't even have to think about on a daily basis besides just taking your medication.
Great. Thank you so much to both of you. Dr. Alexis, they mentioned the importance of staying hydrated, staying warm. Any final words for us to take home as we wrap up this session this evening?
Well, I think it's always good from to hear from people who go through this every day. As Nika said, she's in pain all the time, which I talked about, and basically, you we as the people looking in need to be empathetic to these individuals
Of
because you don't know what they are going through or what is happening, and do not then just brush them off. Tonya seemed to have had a normal life, and just because she had a normal life, which she is entitled to, doesn't mean that she doesn't have complications or have problems. And therefore, when she is, I think people need to be just a bit more empathetic to our patients, all patients on the whole. But as I said before, sickle cell patients always seem to get a bad deal. But yeah, just to be more empathetic, especially if they know. And a lot of the times they don't want to be sick, and they try very hard not to be sick. So you come in and saying, "Oh, you're faking" or something like that is not helping them. We need to be more supportive of helping them through whatever they may be going through.
Thank you so much. Dr. Alexis, I want to say thank you for taking this opportunity. I know you are very, very busy, but taking this opportunity to come out and really talk to our listeners this evening about sickled in pain, sickle cell disease, sickle cell anemia. I am actually seeing here comment. Thank you all for this session, and I feel confident to know that people out there understand because I didn't ask for this. So again, thank you so much, Dr. Alexis. I want to say thank you to our listeners. A special thank you to Tanya as well as Nika, who were brave enough to share their journey with us a bit at the end of the session. And I want to say to all of our listeners out there, have a great night. Continue to be safe and join us and follow us on Podbean and Anchor next week on First Aid Chats by Dr. G, Closing the Gap. Next week, we'll be doing Parkinson's disease. Have a good night,
Okay.
everybody. Thank you so much,
Good
Dr.
night, and it was my pleasure. Thank you.
Thank you. Bye-bye.
Bye.